Okay, so welcome to this next video in which we're discussing pathological cardiac hypertrophy. Now, we're just having a brief revision of how beta-1 stimulation of the cardiomyocytes increases the force of contraction of the cardiomyocytes. Okay, so we've seen how beta-1 stimulation causes these cyclic AMP oscillations, and when the cyclic AMP is high, it's going to activate protein kinase A enzymes of both the type 1 and the type 2. And we're now looking at the complexes that exist within the heart which anchor the type 2 protein kinase A's close to their targets. So we've seen this complex here involving the muscle-specific A kinase anchoring protein beta, which holds the type 2 protein kinase A and the adenylyl cyclase 5 close to the type 2 ranitidine receptor. Now let's have a look at another complex involving the L-type voltage-gated calcium channel. So basically what you have this time is the ACAP79. So here is the ACAP79 here, and it will again be ACAP79. It will again be bound to proteins in the membrane. Okay, this time not the adenylyl cyclase. Okay, so it will bound to proteins in the membrane. So this is the plasma membrane again, and then it will also be bound to the L-type voltage-gated calcium channel here. So this is our L-type voltage-gated calcium channel. And then of course it will have this type 2 protein kinase A held nice and close as well. So again, it's going to target the activity of this protein kinase A to this phosphorylation of the L-type voltage-gated calcium channel. So when cyclic AMP binds in these 4 cyclic AMP binding sites, what will happen is the catalytic subunits will be released, and they'll be released directly on, basically, to this L-type voltage-gated calcium channel here in pink. Okay, and they'll phosphorylate that L-type voltage-gated calcium channel and increase its conductance. And it's worth also saying that in both of these complexes that we've seen now, where we had before MACAP beta, and here we have ACAP79, that it's very likely that the beta-1 adrenergic receptor will also be linked to this great complex somehow. So maybe it will be linked to other proteins which are bound to the ACAP79. It's not directly linked, but maybe indirect links will have it there. Then what you can imagine is that you'll have these huge, great signaling complexes, basically. So here's the beta-1 adrenergic receptor. Then in between, beta-1 adrenergic receptor. Then you'll have the G protein in the middle here. Okay. And then the adenylyl cyclase may well be linked as well. So you'll have basically all of the components of this signaling pathway all together. Okay, let me just add one more transmembrane domain there. All together in the membrane, basically, so that one will activate the next thing, which will be next to the thing that it's going to activate, which will be next to the thing it's going to activate, etc. So you have these large signaling complexes. So that is how you target these protein kinase A's of the second type to their targets, which are in this case the L-type voltage-gated calcium channel and the type 2 ranitidine receptor. Okay, so one last thing I want to talk about, which is quite simply another agonist for the beta-1 adrenergic receptor. So the drug that you would use experimentally to try and stimulate cardiomyocytes is the drug isoprenaline. So I just want to talk briefly about isoprenaline. Okay, so isoprenaline is a selective, well, it's actually a non-selective. It's a non-selective beta agonist, basically, beta adrenergic agonist, and it's also got the name isoproterenol. Okay, so this is an agonist for the beta-1 and also the beta-2 adrenergic receptors. Okay, so it will bind to them and activate them. Okay, now I want to show you how similar its structure is to noradrenaline. So let me show you the structure of noradrenaline first. So noradrenaline has this benzene ring right at the end here, with 2 alcohol groups coming off it, one here and one here. And basically, when you have a benzene ring with 2 alcohol groups off it, and by the way, this is not the full structure of noradrenaline, don't worry. This is called a catechol ring. So that's why you'll often hear noradrenaline, and in fact adrenaline as well, and in fact dopamine as well, so dopamine you can add to this. You'll hear them referred to as the catecholamines, because they have this catechol ring in, and they also have amine groups as well, so they're the catecholamines, okay, or the catecholamines for when you're saying it quicker. So, continuing this structure on, you then have a carbon coming off, which has an alcohol group off like that, another carbon with 2 hydrogens coming off here, and then in noradrenaline you just have an amino group right at the end like this. So this is the structure of noradrenaline. Right, so now let's see the structure of isoprenaline or isoproterenol. So basically what we do is we slightly modify this structure here. Okay, so you keep all of this bit the same, so you've still got the catechol ring with these 2 alcohol groups off the benzene ring. Okay, then off here you have the carbons coming again with this alcohol group here. Okay, another methylene group. Then finally you have this amino group again, but now you've linked a carbon off it. And this carbon then has 2 methyl groups coming off it, so 1, 2, and also a hydrogen like so. So that now is the structure of isoprenaline or isoproterenol, which is this non-selective beta agonist. So this is the drug that you'd use experimentally to stimulate beta-1 receptors on cardiomyocytes. Okay, and basically if you take a hypertrophied cardiomyocyte and stimulate it with beta-1 agonists, you don't get much of a response at all. You don't get an increase in inotropy of the heart nearly as much as you would in the case of a healthy, normal cardiomyocyte. So overall, we've seen that in pathologically hypertrophied cardiomyocytes, you have a much lower force of contraction anyway, i.e. just with regards to producing a calcium signal, the amount of contraction you get for that calcium signal is reduced. In addition, what you have is, if you stimulate the cardiomyocyte with beta-1 agonists, such as isoproterenol/isoprenaline, they're the same thing, basically the increase in the force of contraction that you see is hugely reduced compared to the healthy cardiomyocyte.